So, very good morning, everyone. I think my job becomes a little easier because Dr. Suma has already given you an introduction to what a muscle transplant is. So, is it an answer for the large angle strabismus? That's my talk. So, let's first understand that what's a large angle strabismus. So, anything that cannot be managed by a routine two-muscle surgery using the routine surgical dosages can become a large angle strabismus. So, give or take, it would be more than 60 PD, and that becomes a unique surgical challenge because you have limited treatment options. So, what are those? You can go for 3 or 4 muscle surgeries, but the reference table are mainly designed for the 2 muscle surgeries. Then, second option could be you could do a stage surgery, one eye, later on followed by the other, but the surgical cost and the hospital stay becomes higher for the patient. And if the patient is one-eyed, then there is definitely unwillingness for the fellow or the better eye surgery. So then what can you do in these cases? Well, you can do extra recessions, which is supramaximal recessions or hangback recessions. But there is risk of creating incompetence by doing these surgeries. There could be limitation of movement on extremes of gazes or alteration of the palpebral aperture width. People have also described augmenting recessions using botulinum toxin or spacers. And one such a good option which is available is a recession resection along with a muscle transplantation. So as Dr. Ma'am has already described, that what you do in a muscle transplant is that you are using the tissue which would otherwise have been discarded, the resected tissue. So I would say that it's a very, it's a very eco-friendly way of utilizing the tissue. You're not wasting anything. So you are kind of transplanting the tissue which would otherwise would have been discarded to the recessed side, and that is kind of adding to the recession. So that gives you an extra recession along with the spacer. So I have been doing muscle transplantations in large angle ESOs and exos and have achieved pretty gratifying results in most of them. So this is one example, a female patient, she has a large angle ESO, more than 80 PD, and we planned a resect procedure. So we did a LR resection, which is 8 mm. So we have to consider the contraction factor of the tissue. So the tissue contracts by around maybe 30% or 40%. So you get an effective spacer of around 6 mm. Maybe 5 or 6 mm. So you are adding to the recession of 6 plus 6. So approximately a 12 mm recession is what you are able to achieve. And this is the serial post-ops of the patient. As you can see, at 1 week, you see an overcorrection and a little hypertropia. So hypertropia is because we miss the inferior oblique overaction, and that can happen, especially if the strabismus is large. This overcorrection, I would say, you notice that the MR action is not fully recovered in adduction. So as you can see. Then wait for 1 month. At 1 month, you see that the overcorrection gets better, and the hypertropia is still a little evident, and so the adduction recovery. So the recovery movement on adduction improves. And this is the 3-month post-op of the patient, where you see that the patient appears to be pretty okay. A little hyperopia is not much of a botheration for the patient, but yes, the adduction limitation, as you can see, is -1. But I must tell you, this is one of the earlier cases that I was doing. So here I was dissecting a little less. But then I started dissecting a little more. I think you should dissect a little more than you would do in case of a normal resect procedure. So this is a similar case with a similar planning that we did in this, but of course with a better dissection. So this is the 3 months post-op of the patient. And as you can see that the patient is not only well aligned, there is minimal change in the palpebral fissure width. So this is pre and post. And also look at the limitation. It's hardly -0.5 as compared to the other side. So acceptable. So it's important, I think dissection is very important while you are planning or doing extra recessions or any supramaximal recessions. Now this was a paper that was published by Dr. Jethani and his team, and they have achieved a good correction of around 90 prisms and stable results for at 2 years follow-up in cases of large angle esotropias. Then coming to exotropias, this is a patient, large angle exo, you see an A pattern, there are bilateral superior oblique overactions. So we planned a transplant procedure along with bilateral PTSOs. So this is the post-op of the patient. Again, have a look at the serial post-ops of the patient. 1 week, the patient appears to be well aligned, but look at the limitation. So we are concerned about the limitation on the recessed side. So you see a little -1 limitation. At 1 month, it reduces, and at 3 months, it's kind of similar. So you see that the alignment, the palpebral fissure width, and the limitation of movement, it's all acceptable provided you have done a proper dissection. So this was a study that was published from a center by Dr. Amar Pujari, and he has achieved good results of correction of around 80 prisms in large angle exotropias using muscle transplant with minimal limitation in abduction. Now this is an interesting case, as Dr. Suma was just describing, that in residual cases of exotropia, you can attempt muscle transplantation. So this patient had undergone bilateral LR recessions around 6 mm in 2013, presents to us with a large angle exo. So there is a bilateral inferior oblique overactions as well. So we explored the LR. We found that the LRs are at 6 mm. So we planned a further recession to 12 mm from the original insertion, and we added the muscle transplant to this recession. So it kind of made a recession of around 16 or so, or even more than that. And this is the pre-op. So you see it's not fully corrected, but look at the marked correction that we have achieved. So it was around 100 PD before, and it's reduced to around 30 PD. So almost a correction of 70 prisms you have achieved with a single eye surgery, and the limitation is not that much. Now since this was a recurrent surgery, you may have scarring or fibrosis of the conjunctiva, and when you are planning such large recessions, you might have to also do conjunctival recessions. So in these cases, like I prefer to put a AMG, as you can see in the ASOCT image, because that helps in the healing of the ocular surface better. So if you look at the advantages, it's a unilateral surgery, can be done in single sitting, minimal limitation of ductions, minimal change in palpebral aperture, learning curve is simple, and there is no risk of graft rejection. In the disadvantages, well, it's a little tedious surgery, a little longer time than the usual recess-resect procedure. There are lack of standard guidelines and dosages, and of course, you have to keep in consideration the contraction factor that happens, because supposedly this is the MR recession that I did in a case. It was 6 mm. After you have resected the tissue, it shrinks immediately by 50%, so around 3 mm. But once you have attached to the recessed muscle, it further expands a little. So approximately a contraction factor of 30 to 40% is what I consider. And eventually the tissue is replaced by the fibrous tissue, but it's important that good muscle-to-muscle attachment must be obtained, and because that is the key to preventing any complications. So although there are no established guidelines, but this is one the surgical dosage. That's a table that's available in a beautiful paper in JAPOS 2019, which you can use as an initial guide, and later on you can titrate your dose based on your surgical experience. So that's just a transplantation video, only if we have time, because I've already exceeded the time. So I'll just quickly run through it. So this, we are hooking the medial rectus muscle. This was being done for the large angle exo. So once you have hooked the medial rectus muscle, now key is that you need to dissect it carefully. You have to dissect a little extra. Okay. Sorry. I think it's, yeah, so once you have dissected, so then using two double-armed 6-vicryl sutures, you need to pass it and secure the muscle fibers, just as you would do for a muscle resection procedure. But the extra step that you need to add is you need to pass another suture at the insertion. So that is also a 6-vicryl suture. Then what becomes important next is to resect the tissue carefully, because you cannot waste even a single inch of a tissue. In fact, inch is too big a word. So you cannot, you just cannot afford to lose any tissue. So you have to cut it carefully, cut it out carefully. You see that the tissue immediately shrinks now. And then you put rest of the, just put the muscle back in position. You need to attach it to the original insertion, just like you would do for a resected muscle. And now going to the other side. Here we are exposing the LR. You need to nicely dissect it out. Again, you pass the sutures at the insertion just like you would do for recession. But remember, here we use a non-absorbable suture. So after you have disinserted the muscle, we take the mark. In this, it was planned to be at 9 mm. So we place the scleral marks at 9 mm. And then you attach this resected tissue, chunk of tissue, onto the recessed muscle. So you see that the muscle has already shrunken, the tissue has shrunken. Now this passing of the suture is really important, muscle to muscle attachment, to avoid any kind of a muscle slippage. You must secure this attachment carefully, pass extra knots if needed. And this lengthened muscle finally is sutured onto the sclera at 9 mm. So it's 9 mm of a recession along with that spacer tissue of around 3 to 4 mm. So that is the effective recession that you achieve. So that's how we are just passing the scleral sutures. And then you can close the conjunctiva using either the glue or the vicryl sutures. So I think muscle transplant is a good option, but you have to dissect it carefully. And in exotropias, now since the amount of tissue that's available for transplantation is very less, so you have to, while dissecting and kind of harvesting the tissue, you have to be careful. Thank you.